Thank you so much for that lovely introduction. Thank you, Dr. Abhay and the rest for having me in this course. It's truly a honor to be a part of this. How do I enhance the use of multifocal IOLs in my practice is the topic given to me. These are my financial disclosures. I am a speaker and a travel support I do receive, and some of them are involved in the manufacture of multifocal intraocular lenses. Harold Redley said in 1950s that the first complication of cataract surgery is aphakia. And Richard Lindstrom quite nicely put it in the late 1990s that the first complication of IOL surgery is presbyopia. I myself have been putting in intraocular lenses for almost 15 to 20 years now, and have been talking about it also. But then even today, less than 10% of the patients actually get multifocal intraocular lenses in my practice. Cost is definitely one of the considerations, but it's also the fact that both my patients and myself are sometimes decide to stay away from this technology because I cannot completely promise an absolutely good qualitative outcome even after good surgery with these intraocular lenses. What is exactly the reason? It might have been already discussed here, in the sense that when you're using a monofocal intraocular lenses, there is a precise focus of light from a specific distance. But when you're having a multifocal implant, we are talking about a diffractive multifocal, which is essentially a bifocal. Rays of light is essentially coming into focus from a distance and from near. It's essentially the direction of the gaze and the object of regard, which determines what is in focus and what is not. So essentially what is in focus, that's supposing here we have rays of light coming from near object focusing here, it sort of gets defocused over here. From a distance it's getting focused over here. It is this which is causing a halo, which is causing a glare, and that's what is disturbing to the patient, and that's something which the patients have to live with. Basically in optics nothing comes free. When you want vision at all distances, there is a certain amount of compensation in contrast that comes with it. So essentially the development in multifocal intraocular lens technology has been towards minimizing this glare and halos, these negative side effects, and that's where we have progressed. So what exactly keeps me away from adapting multifocal intraocular lenses? In almost every patient who can pay for it is the fact, the fear of poor post-op results, in spite of spending a significant amount of time talking to them preoperatively. Glare and halos, loss of contrast, unsatisfactory levels of spectacle freedom. Even if bilaterally implanted, you can never promise a patient that for all distances they can comfortably do without glasses. And it's also depending upon the type of a multifocal intraocular lens that you put in, it could be a pupil size dependent vision. It's a classical case of garbage in and garbage out. And the moment I started refractive surgery and multifocal intraocular lenses, one good thing happened to my practice is that I started looking at my basic refraction and biometry in a much better fashion. I started concentrating on clinical outcomes. So basically if you are getting a suboptimal refractive outcome, a -2 diopters, a -1.5 diopter cylinder, what to talk about multifocality? The patient is not going to have good monofocal vision. So it's essential whether you use immersion A scan or whether you use laser interference biometry. We often use both of them and compare the results. You must get repeatable results. Also, you must be choosing the right kind of formula. I've completely shifted on to the Holiday 2 formula, which is available with my Varion instrument. The more the number of variables that a particular equipment takes into consideration, the formula takes into consideration, the more precise is going to be the intraocular lens power calculation. And we take 7 different variables. We essentially feed in data both from the LensStar or the immersion A scan and from the Varion. And this is an important slide as far as I am concerned. I think more than listening to lectures, more than reading books, you also need to look at your own post-operative results. You learn your own surgical videos. You learn a lot from that and refine from that. Look at this analysis on a particular day, not necessarily multifocal lenses, monofocal lenses, done in the year 2006 by me. And this is what I found, -1.25 with -0.5, 6 weeks post-operative, -2 with -0.75, -1 diopter cylinder at 90 degrees. Obviously, these patients, if I had put in multifocal implants, there's no question of these patients being happy. I would have to refine the quality, the kind of refractive outcome that I had got. Look at these results now that I'm concentrating much more on this. In the year 2015, you can see almost all of them are plano, except for some residual astigmatism. Of course, here it's -1 diopter. I think today we owe it to our patients and ourselves to achieve within 0.5 diopters of residual spherical error and about 0.75 to 1 diopter of residual cylinder error. Of course, if cost constraints and because of which the patient cannot afford a toric intraocular lens and there's a significant toricity on the cornea, there might be some cylinder that you and the patient have to live with. As Dr. Vasada is already alluding to, now you have the freedom of choices and you can pick and choose what exactly the multifocal intraocular lens that you want to implant. 2.5, 3 is what's available from the Resto platform. And another platform that I commonly use, that's the Technis multifocal intraocular lenses. There are nuances of differences between these two, but provided your choice of lens and handling these lenses is right, most often with either platform you end up getting excellent results. So look at the defocus curves here, and that's something you need to understand. You have a precise focus for distance over here, and the second hump over here, which essentially determines the near vision. And the distance of the near vision is essentially determined by the add power in the lens. It could be 50 centimeters, 42 centimeters, 33 centimeters. And it essentially is a function of the number of rings. More the number of rings, more likely the amount of dysphotopsia. That's the reason the Symphony lens, the knee kit out of the block, which has certain specific design modification, the HLA design, the achromatic technology, I'm not going to go into the details, and also the fact that it has lesser number of rings, that is 9 in number, is somewhat better as far as the quality of vision outcome is concerned. But that's not the point of discussion today. What I need to do is to customize the lens to the patient. It's already been referred to, but what's my take on this? I customize the lens to the patient. Right from beginning, the height of the patient determines the arm length of the patient. If it's a pretty short patient, he or she is going to hold the book at around 25 or 30 centimeters. If it's 6 feet 4 inches, he's going to hold it at 40 centimeters. So essentially, for a tall patient, I am more inclined to select a 2.5 diopter AD patient. Depends upon the intraocular lens that I'm putting in. If it's a 4 diopter AD intraocular lens like the Technis, the original Technis lens, which translates to a 3.2 diopters for near, then obviously I am not going to increase the amount of basic power that I am putting in the patient. I do not want to steal some amount of near vision in that patient. But if it is a 2.5 diopter AD, I would err more on the side of bumping up the power. I hope you understand. If it's a 21 and I'm putting a 2.5 diopters, I'm more inclined to put a 21.5 rather than decrease it to 20.5. And it is vice versa when I'm having a 4 diopter AD. And the most important factor that I want is the reliable refractive outcomes in the first eye. We are never promising total spectacle freedom as far as these patients are concerned. What we are telling them is relative spectacle independence once they are bilaterally implanted. Depending upon the outcome in the first eye, I titrate the power that I am putting in the second eye so that bilaterally implanted, they are reasonably effective for all distances, distance near and intermediate. So the refractive outcome, the comfort level of the patient for all distances in the first eye is extremely important for me to determine what exactly is the lens power that I'm going to put in the second eye. And this is something you may have a very experienced optometrist, he might be able to guide you on this, but I do call my patients at least the evening before the second eye operation, have a discussion with them and decide on the power that I'm going to put in the second eye. What is this blended vision and micromonovision? There might be certain nuances as understanding, but my understanding, my principle is that when I'm talking about blended vision, it's essentially the same kind of intraocular lens. 21 diopters I get for bilaterally, I put 21 diopters, but the non-dominant eye which I want for near, I put plus 3 diopters, and the one which I want for distance, I put plus 2.5 diopters. What is micromonovision is what I was alluding to earlier. That is, we may play with the basic power of the lens, maybe put in a 3.5 diopter AD lens in both the eyes, but titrate the basic power 21 diopters or 21.5 diopters. There's a lot of noise about low AD multifocals, but mind you, at least in my practice with the kind of patients I deal with, even today a plus 4 diopter is very much a part of my armamentarium. There are a lot of 70 years old, 80 years old who do not drive in the evenings, who just want to pick up their paper in the morning and read it comfortably without reaching out for glasses and just watch TV and once in a while go out. For them, a plus 4 diopter AD is an excellent lens and I still continue to go ahead and use it. Delay prescription of glasses. Just like learning cycling, patients have to get used to these lenses. And just because on the first post-operative day or 1 week later the patient is not happy, don't be in a hurry to prescribe glasses. Delay them, tell